meet the girl one time, and she sends you a letter saying she's in love with you. Stay away from her. Borderline personality disorder. Because the next letter she sends will be to the police saying you raped her. Okay? It's a problem. Because they lie all the time. Okay? Men can have it also. But this is mostly in women. Now, some people have tried to give MAOs, but it helps just very, very little. Okay? It helps very, very little. In a sense, they're like sociopaths. Except this is with personality. And then wherever they go, they cause drama. Okay? Every place they go, the drama cause problems. Borderline personality disorder. The only treatment is stay away from them. Okay? Because the medications will fail. Huh? Atypical depression is most people when they're depressed, they eat less. Okay? And they sleep less. Most people when they're depressed eat less and sleep less. Atypical depression, they sleep more and eat more. Atypical depression, sleep more and eat more. Normal depression, you eat less, you sleep less. Okay? But these MAO inhibitors can help these disorders. Very little help for this one. I should probably erase it actually. It doesn't work very well. Okay? Do not, if they're on an MAO, they have to watch their diet. They have to watch their diet. Now, we go more complex. There's actually two types of MAO inhibitors. MAO-A and MAO-B. MAO-A breaks down epinephrine, norepinephrine, serotonin, and dopamine. Okay? So our medications were blocking mostly MAO-A. Okay? There's actually two types. Now, there's some people who are depressed all the time. Okay? They may have a mutation in MAO-A where it's too active. It's too active. So whenever they produce serotonin, dopamine, or norepinephrine, they break it down real fast. So these people, because of genetics, are depressed all the time. Because their MAO is too active. Okay? These people would respond very well to an MAO inhibitor. If this is what's causing the depression. Genetic, everyone's genes are a little bit different. So some, their MAO, monoamine oxidase, which removes nitrogen through deamination, if it's too fast, if it works too well, it'll cause depression. MAO-B, okay, is associated, it's too much, with Alzheimer's disease and Parkinson's disease. So MAO-B is associated with Alzheimer's disease and Parkinson's disease. So that means what? If you have very fast-acting MAO-B, maybe you lose your mind as you get older. Okay? The reason is MAO-B creates oxygen radicals which damage tissue. So every time MAO-B is working, it's damaging part of your brain. Slowly. Okay? So MAO-A can cause depression if it's too active. MAO-B associated with Parkinson's and Alzheimer's if it's too active. Here it's because of the production of free radicals with oxygen. Okay? So theoretically, if I give an MAOB inhibitor, it should slow down the progression of Parkinson's and Alzheimer's, slow down the progression. Okay, so this is how you develop drugs, right? You know how things work. Okay? Any questions so far? And again, depression. The medications will upregulate the neurotransmitters. Okay? But what happens if I upregulate the neurotransmitters too much? Patient can become what? Or manic. Or manic. Okay? These are some of the other foods that contain tyramine. You do not use tyramine with MAOs, inhibitors, cheese, cured meats, sauerkraut, soy sauce, fava beans, beer, and wine. Would you guys eat this? Why do you eat fava beans? Why do you eat fava beans? It helps depression. So now you know why you eat fava beans. Okay? All these have tyramine, which helps release norepinephrine, dopamine, and serotonin to a less degree. So now you know why you eat beans. Everything's for a purpose. That's why you're hungry for something, right? Maybe you're protein deficient, so what happens? You feel like eating meat. You're depressed. I'm going to have beans, maybe with meat, with cheese. Everything you do is for a reason. You may not know it, but there's a reason. You may not know it, but there's a reason.
That's why that's going to be our favorite food.
What?
That's why we have favorite food.
Yes. Yes. Because it's replacing something unique. Raises dopamine means what? You enjoy it. Right? Serotonin, I want to eat more of it. Right? Norepinephrine wakes you up. Damn it, I'm hungry now. Right? So that wakes you up. The serotonin says, I'm going to walk to the store to get it. And then dopamine is, this tastes good. Okay? Everything's biology. Okay? Soda? They have caffeine in it. That caffeine helps wake you up. Like coffee. It's a different mechanism. But both caffeine works on what's called a xanthine receptor, which increases intracellular cyclic AMP. Just like the receptors at the beta-1 receptor increases cyclic AMP. That's why if I have coffee, my heart starts to beat faster. It's a different way. It gets around beta-1. Okay? Here's how tyramine works. Okay? Tyramine comes in, kicks norepinephrine out. Okay? So the neuron takes in tyramine, kicks out norepinephrine. This stimulates the receptors. So that's how your food is working. Food's rich in tyramine, release norepinephrine. Okay? It will also release some dopamine, some serotonin. Okay? Foods like that you eat also will have tyrosine amino acid or tryptophan. That will take longer. That'll help synthesize these neurotransmitters. That takes longer than releasing what's already there. That'll take longer. Okay? It'll take longer. Okay. Now we're going to look at antihypertensives. Okay? Real quickly. Next year you'll have a lecture. But we have ACE inhibitors, calcium channel blockers, diuretics, beta blockers, sympathoplegics. Quickly, ACE inhibitors block angiotensin II, so less vasoconstriction, less aldosterone, less water. Calcium channel blockers dilate the blood vessels, slow down the heart. Thiazides, you get rid of liquid. The more fluid, the more your heart contracts. It's called, what law is that called in physiology? You have physiology of the heart yet? We should have talked about this. This is going to be on your boards. What's it called? No, you guys have physiology of the heart. Huh? No? In Arabic?
No.
Or bad English?
Bad English.
Say that. Okay. I know. Can't lie to me. Can't lie to me. I can read your mind by reading your body language. Okay. Very bad English, right?
It's good.
The English was so bad, you just fell asleep, right? Yeah.
Not pronunciation.
Right.
It's a different thing.
I know. It would have been probably better to give it in Arabic. You should understand something. Okay.
What does it called?
What? Sympathoplegics. All right. If all this fails, our last line for hypertension is sympathoplegics. Okay? Last line. But you already know what the sympathoplegic does. What receptor does the sympathoplegic hit? What receptor do the sympathoplegic medications hit?
Alpha 1.
Just think about it.
M1? No.
Alpha 2. It has to be alpha 2. That downregulates everything. That's the sympathoplegic. So who said alpha 2? You? So one person studied last time, right? Alpha 2. It has to be alpha 2. Because that downregulates everything. Okay? One of the drugs is called clonidine. Clonidine. You may have relatives on this. Okay? Clonidine. This binds alpha 2. It tells you sympathetic, stand down. Do not release norepinephrine. Do not release it. Okay? We use it for high blood pressure. Some people use this for attention deficit disorder. You know what it does? It just knocks the child out. So, it knocks them out, right? Like that. So it's not, that's how it works. Anxiety. Withdrawal syndrome. Maybe the person's an alcoholic or on drugs. Now they start to withdraw. Give them this. Okay? And then you can give them migraines and menopause. But the big reason you give it is two.
High blood pressure.
High blood pressure. Second is withdrawal. Withdrawal second. Next time I'll make the slides, I'll put this in dark, put this in dark. That's the most important. Hypertension and withdrawal syndrome from opioids, from narcotics. Narcotics are the drugs where the person makes them not like cocaine and methamphetamine make them up, right? Opioids are the other way. They make a person really calm. But when they withdraw, they go up. So this is good for withdrawal from opioids and alcohol. Opioids and alcohol, clonidine. This calms them down. Calms them down. Okay? Methyl-dopa acts like clonidine. It's another drug. It's converted to methyl norepinephrine, and it binds the alpha-2 receptor. So this acts like its metabolite of methyl-dopa is methyl norepinephrine. This binds alpha-2. So both of these do the same thing. Okay, clonidine and methyl-dopa. This will bind alpha-2. It's good for coming out of narcotics or the hypertension. What happens when a person's on clonidine or methyl-dopa? If they try to stand up out of the chair, they get dizzy and can fall. They get dizzy and they can fall. Okay? When you stand up, you activate the sympathetic nervous system for vasoconstriction to make sure enough blood goes to your brain. Okay? If I have this blocks the sympathetics, so when they stand up, they cannot vasoconstrict. Not enough blood goes to the brain, they pass out. Okay? That's called orthostatic hypotension. Orthostatic hypotension. Orthostatic hypotension means if they stand up, blood pressure drops too much. Stand up, blood pressure drops too much. Okay? Very strong. We'll see how this works. Okay? So here we want to release all this norepinephrine, but by blocking it with clonidine, I stop it. I stop it. Are there any questions so far? So if I give an alpha-2, I stop the release of norepinephrine. No more sympathetic. Knock shuts it down. This is a sympathoplegia. Sympathoplegia. Okay? Everything has a reason. Okay? So let me find out how much you learned. If I give you too much, let's say you're dehydrated, and I give you too much fluid too fast, what happens?
Sure.
Didn't you guys just have fluid therapy?
Yes.
Yeah.
Did they cover this? No.
Today we have.
Did they? So you tell me what happens if I give you too much water too fast.
I think it's because
Pulmonary edema.
What?
Pulmonary edema.
Worse.
Water toxinic.
What happens?
Edema, something edema.
Pulmonary
Edema.
Because of cerebral edema of the brain,
Edema.
demyelinization of the spinal cord, permanent paralysis. Did you discuss that?
No.
The difference between reading about it and having patience. Okay? What's Ringer's lactate? What's Ringer's lactate?
Stations when you have acidosis.
You have what?
Acidosis.
Acidosis. What's Ringer's lactate?
You have acidosis.
What's Ringer's lactate? That's not the question. What's Ringer's lactate?
Ringer's lactate. Sodium chloride with
The what?
Kind of the crystal.
With what?
I mean, component.
IV fluid.
Let's
How much sodium chloride is in Ringer's lactate?
0.9. Maybe
See, this is my point. Okay? Without knowing what's in Ringer's lactate, you'll kill the patient. Okay? You'll kill the patient.
Does it have a lot of chloride?
No, low amounts of chloride, low amounts of sodium.
Lots of
Okay? That's my point. All right? So when you go to the hospital with this information, your patients could die. Right? This is why I want you to, the dean wants you to, the president of the school wants you to, and the king wants you to read.